Hi, my name is Chris Lee. 2 days ago, I was sitting in my home in Perth where it was 38 degrees, lovely, sunny, shining. Now I'm in Amsterdam where it's 2 degrees and it's quite a surreal change. But I'm looking forward to presenting today my ideas about how to integrate schema therapy with EMDR and to show you how that would work in practice with some clients. Now, the overview of what I hope to cover today is firstly to discuss the similarities between EMDR and schema therapy. And whilst they share many common tenets, there's also some differences. And these differences, I think, can really enhance the treatment outcome when you can combine what is unique and best about both approaches. I'm also going to illustrate the enhancement of the combination of these two therapies with a particular technique known as memory mapping. So memory mapping is a case formulation technique that is really useful for helping clients get distance from their experiences and their schema. It helps the therapist work with the client to develop a shared formulation of what's happening for them. And it really assists in choosing targets for emotion-focused approaches. I'm then going to conclude with discussing specific benefits of integrating EMDR and schema therapy. Now, in this slide here, I have focused on 4 areas where there's some shared ideas between EMDR and schema therapy. The first is they share some ideas about common origins. In schema therapy, the idea is that early maladaptive schemas are developed through aversive experiences in childhood. It particularly focuses on experiences where the child's core needs are not being met. Similarly, EMDR focuses on assessing the past aversive experiences that are dysfunctionally stored in the person's memory network. The next phase is that both therapies share an assessment phase. In the assessment phase in schema therapy, what the therapist tries to determine is what are the schemas and the relevant coping modes. In EMDR, what you try and do is determine which key memories are central to the development of the psychopathology. Each approach also has a preparation and education phase. In schema therapy, what you try and do is develop a shared understanding with the client of the schemas that are involved, the origins of their schemas, and how they have behaved and maintained the schemas. In EMDR, there's a development of a shared understanding of how the AIP model impacts the relationship between the person's dysfunctionally stored memories and their psychopathology. The final area that I want to talk about is the change process. And both models share that the change process happens through cognitive, behavioral, experiential, and interpersonal techniques, the combination of these. In order to understand the synergies between the two approaches and the differences, I'm going to talk to you about a study where we compared traditional emotion-focused approaches used in schema therapy, in this case imagery rescripting, with EMDR. So in this study, we treated patients with PTSD, either with imagery rescripting or EMDR. It's called the IRAM study because the IR stands for the imagery rescripting component and the EMDR for the EMDR component. Now, most participants in this study had to wait for treatment, which gave us an opportunity to compare what happened during the wait period compared to what happened during the treatment period. The other thing to understand about this study that's important for later is that there was no stabilization in the treatment process. So the first session with the therapist was an assessment session where the memory map was drawn, which I will talk about in a moment. And the second session, you began your desensitization with whichever approach the participant was allocated to. It was an international randomized controlled trial across 7 countries: the Netherlands, Germany, and Perth. And Perth's not really a country, but it did feel that way sometimes. And also across 7 sites. Treatment was twice a week, so most people were treated within a 6 to 8 week period. There were 12 sessions. They lasted an hour and a half each. Other important aspects about the IRAM study is that the average patient in the study was 38. Now, in order to get to the study, they had to identify a trauma from before the age of 16 that was impacting their life now. And they had to identify that with a research assistant who did a CAPS relevant to that trauma experience. The average age of the trauma in the study was 8. Now, typical of these more complex PTSD presentations, most people had multiple traumas. In fact, a quarter of the sample reported to the research assistant they had 1,000 or more traumas. So a participant like that would talk about experiences of sexual abuse that began at the age of 13 and that concluded when it was discovered at the age of 16, and then say something like, and it happened every day. So the research assistant would say, yes, that's more than 1,000 traumas. So the clinical issue becomes, how do you choose what is the relevant treatment target where you have so many traumas that you could possibly examine? And also, we wanted to make sure that any treatment on these identified traumas could generalize across the person's experience to maximize the treatment effect. So now just a little bit more information about the study. Of the 155 participants who entered into treatment, 144 completed. So we achieved a really low dropout rate, only 7%. It's much lower than similar studies with this complex population. Also important to emphasize that the treatment was within a very brief period of time, 6 to 8 weeks. Now what you have here is the primary results as measured by the CAPS-5, which was administered by a research assistant that was independent to the treatment process. What you can see from the graph here is that during the waitlist period, very little change in any of the PTSD symptoms. During the treatment period, also 6 to 8 weeks, you get these massive treatment effects. And then at the first follow-up period, which is also 8 weeks after the treatment period, the effect sizes are really large, 1.7 for both treatments. This here refers to 1 year after receiving treatment. So at this longer follow-up, you can see that people's treatment gains were certainly maintained, if not people made further improvements during the follow-up period. So much so that 81% of the participants entering into this study no longer made criteria for post-traumatic stress disorder at this 1 year follow-up. So you're probably thinking, well, if it's complex PTSD, what about the other symptom picture that's typical for this population group? So we looked at a range of measures that you would be interested in, such as shame, disgust, hostility, interpersonal sensitivity, concept of self. There wasn't, in fact, a different picture for any of those symptoms. It's all the same. No change during the waitlist period, massive changes during the treatment period, and that this improvement is sustained during the follow-up assessments. Now, I'd like to talk to you about a technique that was used in the first session of IRAM to help get a map of people's trauma experiences relevant to their presentation. So although it was developed for working with chronic trauma, I find that in my everyday clinical practice, it can be used for any schema or EMDR intervention for general issues, not just for PTSD. So the couple of benefits of this, as you will see when I demonstrate the technique and when I work with the clients later, it does help facilitate an understanding for the client of how their key experiences are related to their sense of self and to the affects that they experience. It also helps them get some distance from those experiences. And at the same time, we're actually activating their entire network of memories relevant to the schema, relevant to their psychopathology. And my view is that this process helps get generalization from the 4 or 5 memories that we're able to treat in the 6 and 8 weeks across their networks of sometimes hundreds or even thousands of trauma experiences. So I'm now going to talk to you a little bit more about the details of what happens in a memory map. So memory maps were influenced by information processing models of trauma. It replaces more list-based alternatives. So those of you that have worked as a trauma therapist with EMDR, say, or prolonged exposure, it might be common for you to construct a list of the traumas that a person has experienced. Also, some of you that are doing schema therapists are used to doing something called the historical test, which is a list of key emotional experiences that the person had throughout time. So before primary school, during high school. And many therapists use these lists to help inform clients about the relationship between these experiences and how they think and feel today. However, I think that list-based approaches has some limitation. The memory map that I'm about to show you is more visual, and it's a more associative-based technique, which has some advantages, I think. And I hope to talk about those in a moment. Now, the slide is showing a diagrammatic representation of the key elements of a trauma memory. So it's based on information processing models, really originally from the work of Lang, and then in the 1980s by Foer and Kozak. Then in the 1990s, Emily Holmes and Chris Bruin added some material. And in the following decade, again, Chris Bruin and Emily Holmes added some more, and our research group has added ideas about how this model would work. The essence of it is this: trauma memories are stored differently in the brain. Trauma memories have 3 crucial elements to it. These elements are information about the event, which is rich in sensory detail, information about the emotions or a behavioral response that a person has, and interconnected closely with that is the meaning that someone gives to the event. So if I illustrate that with a client, I had a Vietnam veteran who had PTSD from combat experiences. And whenever he thought of his combat experiences, his mind would flash onto a memory of seeing rice paddies underneath him and hearing the whirl of a helicopter blade and seeing opposite him a guy with a white face and spots of red blood on this. Now, as that experience entered his mind, he would experience a churning feeling in his stomach and a sense of wanting to hide. And interconnected to that was an idea like, I'm bad, I'm responsible. So just to pad that out for you, my client was a platoon leader in Vietnam. So he saw himself as responsible for the welfare of everyone in his unit. On this particular day, a soldier who had no combat experience was brought into his unit. And my platoon leader is taking him, the rest of his platoon, on a mission. And he said in his mind, he wanted to really make sure that this new soldier would follow his military training and not make any mistakes. Unfortunately, the guy made some errors and he was injured. And the image that my client has of that person sitting opposite him being evacuated out of the field in the helicopter. The next part of the model is to understand that this trauma memory can be triggered by any one of these 3 components. So if my client goes for a swim in Perth and there's a helicopter on shark patrol, the sound of that helicopter can reactivate his experience of the trauma memories. One time while I was seeing him, he had a churning feeling in his stomach for the whole week because he had a gastrointestinal bug. Now, during that week, he was flooded by images of his combat experience. Another time while I was seeing him, his son came home from school and told Dad that he was being bullied. My client found himself thinking about his combat experiences. In my view, the relationship was in his thoughts like, it's Dad's job to make sure that your son doesn't get bullied. And if he is getting bullied, it's his job to make sure that you get that to stop. So again, that sense of responsibility triggered the re-experiencing of this. Now, what do these dots here represent? These are the associated experiences, associated memories to this event. Now, some of them are related because they also involve combat experiences. Others are related because they also share the same meaning, a sense of bad or being responsible, and some are associated because they have the same somatic sensation. So to illustrate it further, my client grew up in a family where there was domestic violence, and there were times when his dad would beat his mum. Now, my client along the way actually learned that he could do things that would sometimes stop those beatings. If he noticed that things were starting to go pear-shaped, he could put on a ventriloquist voice and make Dad laugh. Sometimes he could distract Dad by getting him to watch sport on the television, and then Mum didn't get beaten. However, unfortunately, there were experiences where he tried those things and Mum got beaten anyway. And so as a child, he felt that in some way that's his responsibility, and that's what these dots represent here. The final part of the information processing model that I want to share with you that is interesting is it tells us what should happen when a memory has been resolved. And as I work with the clients later today, you might see those changes occurring when the intervention has been successful. So what we expect to see, instead of the event being rich in sensory detail, it should be more historical, it should be less vivid, it should be more faded. We also would expect to see not only changes here, but also changes in the emotionality of the experience. The levels of distress should go down. And then what we find, and this is particularly true for EMDR, is that as the representation of the memory changes and becomes more of a narrative, more of a story, less episodic, and then as the distress goes down, the person becomes more free to experience post-traumatic growth, to make connections with experiences that are incompatible to the trauma network. Once there are changes in these domains, in EMDR, the person particularly starts to think about times when not every man treated them badly, for example, or that they didn't fail at everything that they tried to do. In the next slide, what I'm showing you is how schema theory and AIP model come together with this information processing approach to give us an interesting overview of what's happening for the clients. So the start of this diagram is you see the three key components related to trauma memories there, interconnected into the network because they do tend to be associative. So the AIP model tells us that experiences that are stored in that way, that is what the AIP model would say, these are dysfunctionally stored when they're rich in the episodic detail, then those experiences result in psychopathology. Now the schema model gives us another layer of understanding of what's going on. These experiences combine together to produce a core belief. For example, for a client that might be, I'm bad or I'm worthless. Now schema theory also tells us that the person, once this early maladaptive schema develops, will behave in ways that maintains the schema. So they might surrender to the schema or resign themselves to the schema. An example of that for someone who's worthless is they might stay in a relationship where someone's treating them badly. Alternatively, they might use avoidance behaviours and not enter into relationships at all. Unfortunately, in doing that, they don't get the incompatible information that they're worthwhile. And the third thing that schema therapist tells us can happen is that the person might counterattack against the schema. So instead of believing I'm worthless, they act as if the opposite is true. They act as if I'm special, I'm better than other people. So this is called counterattack. It's sometimes called inversion. In psychodynamic terms, it's called reaction formation. Now, the combination of these set of aversive experiences and the schema really interferes with the person's healthy adult goals. It interferes with their capacity to develop a sense of connections with others is going to be stable and enduring. It interferes with developing a sense of themselves as being competent or capable, and can interfere in other ways, making them feel like they're more vulnerable or have no choices, and mess up the sense of appropriate responsibility. So this slide here puts the whole thing together. Now that leads me to talk about the actual construction of the trauma map. There are three, or memory map, there are three possible pathways for the development of this map. The first one is through a schema pathway. So once you have decided with your client what the schema is, you can simply ask them, so this idea that you're worthless, that you're bad, when did that begin? Or you could ask, where did you first learn the idea that you're worthless or bad? Another way that you can actually use schema information to understand the key experiences is use the client's response to the Young Schema questionnaire. Whether you're doing this or this, your idea is to flash onto the memory and get those three components that I showed you with the pieces of pie. That is the image information, the emotional response, and the thoughts. And an example of how you might use the YSQR in this case is I've put up 4 items that relate to defectiveness. So if in your assessment process you find that a person has put 5 or 6s beside each of these items, a useful clinical thing to do is to ask the client to close their eyes and then say to them, I'm going to read back to you statements that you said describes me perfectly. And as I read them back to you, I want you to notice what experiences come to mind as you think about this idea. And then you would say to them, it is my fault that my parents could not love me enough. And actually leave 20 or 30 seconds for experiences to come to mind. And then the next statement, I don't let people know the real me. Again, leaving 20 or 30 seconds. So the interesting thing is that we find that those memories associated with the activation of the schema in doing this way are often the things that the person is carrying around in their mind that are triggered by everyday events and create this disproportionate schema response to something that might be quite neutral or quite mild. The second pathway for constructing schema maps, and this is what actually happened in the IRAM study, is the person would begin the treatment process in session 1 by sharing with the client key information that the therapist already had. So to get into the IRAM study, the person had to make criteria for PTSD, which means they talked to a research assistant. A trauma memory was already identified, and the research assistant worked to help identify a belief associated with the traumatic memory. So the therapist redirected the client's attention, often the first 5 minutes of their therapy session, to that experience. From there, the therapist would assess in what ways that the client was affected by their trauma. How did it affect their sense of self? How did it affect their behaviors? After seeing how it affected them, then being clear with the client about what it is that they wanted to be different. So I'm just going to keep going with that way of doing it that we used in IRAM, just to give you a little bit more of a feel of what it would look like. So here is, in fact, a trauma map from a patient in the IRAM study. And the therapist began with knowing this memory. So it would be sitting across from the client and saying, I understand from Rebecca, the research assistant, that you have experienced post-traumatic stress disorder. And I understand that one of the memories that you have of this is when you were 4, and it involves sitting on a guy's lap. And then the therapist would have typically an A3 sheet of paper sitting on a coffee table beside the client, point to that and draw this experience here and the 3 pieces of pie, the episodic detail, the emotion, and that. So be saying, so you draw that, you put that in there, and then you say the person. Now, as you flash onto that memory today, what emotions do you experience? And in the session, the client identified that they felt a tightness in the chest and a sense of being dirty or ashamed. The therapist then elicits what idea goes with the image of sitting on that guy's lap and that sense of tightness in the chest. And the client says that I'm bad. The next step is that the therapist then says something like, I'm just wondering, is that the only time in your life that you felt that you were bad? Have there been other times? So you could ask that as a prompt. Other prompts include, we often find that people who've had traumas like this from childhood have other experiences where they felt that they were bad, or other experiences where they felt shame. Tell me if that's happened to you, and if you can, what would be one of those memories? So what we try and do there is elicit these associated experiences. Now, in this particular client example, the second experience that they came up with was this one here, when it was asked, were there other times that you felt bad? He said, yes, when I was 17. He said, I was in a bikie group at the time, and I had a girlfriend, and she was saying that she didn't feel safe and that she needed me to stay home more. I was too selfish and just wanted to spend time with my friends, so I didn't listen to her. But I can still remember the day when the cops knock on the door, and as I open the door, they tell me that they have found her body. So she was killed by a rival bikie gang. So we asked the client to flash on to that experience. He tells us what he physiologically feels when he thinks of that, and it was connected to these ideas there. And then when we ask, is that the only time that you felt bad, or are there other experiences that go with that? He says, yes, I remember this time when I was 8 or 9. Mum and Dad was fighting in the bedroom, and they stopped their fighting. They came running in and said to me, I am the reason that they are fighting. And 3 months later, they separated. So you can see from what I've demonstrated so far, we collect these experiences that are all going to be related basically along the same schema lines, or at least related in the network because they share some of these elements. And then by drawing lines between some of these common factors, for instance, I'm bad occurs here, and it occurs here, it also occurs here, or you can link up the physiological sensations there with that. You are really priming, activating the person's memory network. And perhaps in doing this, that's why we were able to achieve removal of PTSD symptoms in 81% of the participants, even though we only got to work with 4 or 5 of the memories. Other advantages of this approach is that we find by drawing the experiences on the piece of paper, it actually creates a distancing from it. You can talk to the piece of paper, you can summarize the client's psychopathology from this, which would go something like this. Look, I can see now, given everything that happened here, it's no wonder that you feel bad a lot of the time. And given that you feel that way, that in some way you're bad, that you're defective, it's understandable that you told me when people say nice things about you, it feels wrong, it feels really strange, and you try and do everything to get out of that situation. Or that when your wife wants to make love with you, this also feels like wrong, that is not supposed to happen, and triggers a shutdown for you. And then you can motivate them towards treatment. So can you understand then if we take these experiences and change how they are formed in the memory network, make them less vivid, make them less emotional, make them more historical, how that sense of being bad is not going to be strong anymore, and that you'll have more of a sense of you're worthwhile, you're okay. The positive cognition in EMDR. On this slide now, what we have is a series of common prompts that are used by the therapist to continue to elicit experiences relevant to the memory map. Another way that you can do memory maps is to actually start with a recent event and find out in that event a week ago or 2 weeks ago, when you think about it now, what is the image that goes with that? What are the feelings? What are the ideas? And then do float back to other experiences. And the float back technique used in EMDR then can help you construct that memory map in more detail. This next slide just shows that you can not only do this in German and in Dutch and in English, but you can also do it in Japanese. And I just think that the Japanese hieroglyphics look a lot more interesting and pretty than trying to do memory maps in, certainly in English. Now, just some other tips about doing memory maps is that sometimes as you're doing the map, the patient might come up with an idea like this, which is, look, something happened that I feel really bad about, but I don't want to talk about that now. It's too scary for me. What we do in that case is we still put it on the piece of paper as the 3 pieces of pie, at least as much detail as the client is prepared to share. In that way, we're acknowledging that it's probably part of the experience, and should the client change their mind about the decision to share that, it's on the piece of paper. It's part of the schedule for the therapy anyway. The other thing I just want to mention is that although this is a PTSD-focused technique, in the IRAM study, most of the therapists ending up putting what's Shapiro called little t traumas. So experiences of deprivation, experiences of emotional abuse were also put onto that piece of paper. And it's quite interesting, in a study that we did do, those experiences account a lot for the severity of PTSD. It was a little counterintuitive. We thought that the degree of sexual abuse or the degree of physical abuse would correlate most with severity of PTSD, but actually it was the reported emotional abuse and neglect that accounted for more of the variance. But just understanding here that everybody in this population also had sexual abuse, physical abuse, etc. The other thing that can happen as you're doing this technique is the person will come up with an emotional experience that is really relevant to them, but it's not part of the schema that you're trying to focus on. If that does happen, the best way to proceed is to still put it on the memory map. However, when you come to the second stage of drawing links between all of the different experiences, you can just not draw lines to that experiences so that you keep that cleaner. That might be part of a second memory map that you would do for a second schema, perhaps. The other thing we'd like to do is, at the end of the session, what we did in IRAM is certainly photocopy the map and let the client take that map away, sometimes inviting them to add experiences to the map. In providing a copy of their map for homework to take it home and add it, it's actually important that during the session, before you complete the memory map, that you actually have them writing the 3 components of their trauma memory. So as you can see in this memory map here, this is the therapist writing about the different experiences. At a certain point, what the therapist does is to draw the circle with the 3 pieces of pie, but hand the pen over to the client to write down what are the details of that experience when you were 24. What are the emotional responses that go with that? What are the thoughts? Get them to do that in the session means that they have a greater ownership of the shared formulation, and also sets them up for when they do take this home after the session, increases the likelihood that they might add some experiences to the map. Once you have started to do reprocessing, the memory map can be really useful for determining subsequent treatment targets. So often you've begun in imagery scripting or in EMDR on that first memory that was identified, or typically in everyday practice on someone's first memory or their worst memory or something that best represents the schema. You can then, after treating that, get the person to look at the memory map and choose which other experience they feel still carries the most emotional bite and work with them to process that experience. A key thing I want to say about the IRAM is that the average number of memories actually treated in the 12 sessions by the therapist was 4.7. And as I have already mentioned, it is enough to actually get this 81% cure rate. So what are some advantages of this memory map idea? Well, one is because it is associative, it's likely to have a stronger emotional component than something that is sequentially presented. Other advantages is that it can work quite quickly with the person to extract the critical information about various memories and stimulate associative processing within their mind. As I've also already mentioned, it helps establish distancing from these experiences, and it can assist with choosing your therapy targets. I also modeled earlier today how it helps with the client developing insight into how the experiences have impacted them in terms of their thoughts and feelings, and therefore towards behaviour change. The final part of the talk is I just want to conclude with talking about some key ways that I think schema therapy and EMDR, when integrated, can have a really fantastic outcome. The first of these is that in the target assessment phase of EMDR, it is the therapist's job to come up with a negative and positive cognition. Well, schema therapists have spent decades trying to work out the best way of categorizing negative and positive cognition in order to get an outcome. So the knowledge from that research and practical base can really inform an EMDR practitioner of what would be the most suitable negative and positive cognition. So what is that data that shows that the assessment of the schemas will improve their outcome? These points. Firstly, we actually know from 25 years of research that measuring schemas using something like the YSQR is valid and reliable and has predictive validity. We know that's also important in the change process. In many studies, changes in the level of schemas as measured by the YSQ are predictive of symptom improvement even after controlling for initial symptom severity. Thirdly, the scores on the YSQ mediate the relationship between adverse events and psychopathology. Now, this has been demonstrated in eating disorders and depression, and we also demonstrated it in post-traumatic stress disorder. So whilst this was a study of combat veterans who had PTSD, and when we looked at those, we also had a control group of combat veterans who didn't have PTSD. We certainly found, consistent with other studies, that those combat veterans who developed PTSD had an increased likelihood of having more negative childhood events. However, what was important is that this relationship was mediated by their scores on the YSQ. So you can have negative childhood experiences, but if it doesn't trickle on to develop an early maladaptive schema, you're much less likely to develop PTSD. So why not use this wealth of knowledge to improve target selection, or the elements of the targets that are most important to pursue when you're doing EMDR? The second thing I want to say about the integration between the two techniques is that EMDR is fantastic for producing quick change in the emotionality and the vividness of the memory that the therapist targets. Let me just give you some data about that. Remember I said that in the IRAM study comparing EMDR with imagery rescripting, there was actually no difference between the two conditions at post-treatment or at any of the follow-up points. However, when you look at a session-by-session analysis, there were significant differences in favour of EMDR in the early part of the therapy. But as you can see, certainly the imagery rescripting catches up to that, so it's not significantly different here and follow-up. So EMDR has this slightly kind of quicker response. I think it's the beauty of the dual attention focus, thinking of the trauma experience and another task we know in the laboratory reduces vividness and emotionality of the experience. And this can happen, as I said, quite quickly. Second piece of data that really highlights this is we published another paper from the IRAM people looking at which participants had sudden gains in their symptom reduction. And we found an interesting difference between the people with imagery scripting and EMDR. And that was the people in EMDR had, if they had sudden improvements, it was likely to happen very early on in the treatment, like at session 2, right? Whereas imagery rescripting sudden gains happen more after the midpoint at session 7 or at session 9. Now, when I talk about integrating the two, I'll have some more to say about that in a moment. Another way that schema therapy enhances your EMDR abilities is that schema therapy can tell you when the processing is stuck in EMDR, what sort of resource am I going to need to facilitate change? So standard text in schema therapy tells us that if someone has defectiveness or shame as a schema, these are the common cognitive antidotes that you're going to use to try and get the schema to change. These are the common experiential things that need to happen in order to get a construct like this to change. And these are some of the standard behavioural interventions that need to be done. So the decades of knowledge about that relevant to the schema can really tell us in the moment, what resource do I need to add to my EMDR in order to improve the outcome for the client at this particular point. This slide refers to the defectiveness shame schema. The next slide just shows you what are the cognitive antidotes for unrelenting standards as a schema, what are the experiential things that need to happen, what are the behavioural goals. Now, what I'm going to argue is that understanding schema leads to effective resource development. Now, I'm going to draw on some of the qualitative data from the IRAM study for this. So it goes like this. When the therapists and the clients were interviewed at the end of IRAM, they had some interesting things to say about their experiences of doing imagery scripting or doing EMDR without stabilization. One of the most interesting things was that the people who received EMDR said something like this about their therapy. I quickly learned that those experiences really had nothing to do with me. Just somehow they seemed less important anymore, and I didn't need to think about them so much. So that classic distancing phenomena, if you like. Now, no one from the imagery rescripting treatment talked about their therapy experience in that way. But the people receiving imagery rescripting, what they said was, during therapy, I learnt things that I could do. I learnt skills that I found that I could use outside of the session, even in things not related to trauma. Now, just going back to this graph for a moment, what you see here is during the follow-up period, although both treatments, basically you have this sustained improvement, there's a bit of a tendency, if you notice, that the people receiving imagery scripting show this even bigger drop in their symptom level than those doing EMDR. To be clear, this is not a significant difference in the slope between these two, but it almost became a significant difference. So one of the interpretations that I have, putting all of that last bit of data together, is if you had imagery scripting, around about sessions 7 to 9, the therapist is teaching you how to do imagery scripting for yourself. The therapist is teaching you to be an adult and go back to those memories and re-script the experiences in order to feel and think and have a different outcome about the memory. So it appears that the experience of doing that for yourself led to these sometimes sudden gains. And perhaps that explains why during the follow-up period, people with, that received the imagery scripting were using these experiences in other parts of their life to further enhance their well-being. Now, if we see that as the relative strengths of each approach, why not combine the two? Why not do imagery rescripting in the middle of your EMDR session? And that way you get to maximize the early reduction in the vividness and emotionality of the memory with the skill and the different sense of self. In the IRAM study, EMDR therapists were banned from using imagery during the technique because we wanted a clear comparison of the two. But in my everyday clinical practice, as soon as the EMDR becomes stuck, imagery rescripting is likely to be the first thing that I would go to in order to improve the treatment process. And now the final kind of a slide in terms of the points that I wanted to make. I think that understanding schema and a schema approach can help determine what is going to be effective resource development interventions. It helps you know what type of antidote a person needs depending on their schema. The next thing that I think where the two techniques can enhance each other is that both of them do think that the change process involves changing cognition and emotionality and behaviors, and this is done within an interpersonal context. I think though schema adds something to EMDR because there's a bunch of research about these key processes that are important in behavior change. Surrender or resignation, avoidance, or the counterattack or inversion ideas. Without schema training, without understanding this inversion, this counterattack phenomena, you might miss things that are really important. For example, people with social anxiety often have a schema where they feel like they don't fit in or they don't belong. And whilst a lot of times they might surrender to that by not saying very much, at other times they might counterattack, which would look like being overly garrulous in situations or saying inappropriate or outrageous things. Now, the overly garrulous behaviors actually maintains the schema because any of you that have been to a party where someone is talking over the top of you, you have that sense of wanting to move away from them. So unfortunately, my clients with social isolation schema who have this counterattack mode and become overly garrulous, it maintains the schema and the distress for them. My final thing about the advantages, the disadvantages of each approach is I don't have research data yet, but I think that an advantage of EMDR is that it generalizes across the memory network quicker than anything else that I know. A major disadvantage of EMDR is that it can generalize across the network very quickly. So what I mean by that is that for some dysregulated clients, EMDR may not be my first choice. It might be better to do imagery scripting first up to get a more contained response to one memory rather than using a version of EMDR that permits and encourages a free association. Then after you're getting that change, then open up to using EMDR to get the generalization effects. So this would be an interesting idea, I think, that I would like to test out in another research study. So thank you very much for your attention so far on showing the integration between EMDR and schema therapy, and I look forward to hopefully demonstrating this for you in practice with the live clients coming up.